Welcome to the last meeting of the municipal year of the Woking Borough Council Health Overview and Scrutiny Committee. Our aim is to focus on the promotion of public health and patient care, the needs and interests of Woking Borough, and the performance of the local NHS trusts. I'm Alison Swaddle, I'm the chairman of this committee, and with me in the council chamber we have Councillor Jackie Rance, Councillor Sam Akhtar, Councillor Jenny Cheng, Councillor Rachel Bishop-Firth, and Councillor Michael Firmager is with us on Teams, and Councillor Barry Patman is here with us in person. We're going to be welcoming some officers and representatives of the trusts. We'll begin with apologies, please, Madeline.
Councillor Maher and Councillor Mather. Thank
you. Members, if you could give your attention to the minutes. We have two lots from the 19th of January and the 21st of February. And if you have any comments or amendments to put forward. Rachel.
Yes, there's a reference to the toilets in Peach Place being a Woking Town Council toilet. I believe it's a borough toilet. Thanks.
Okay, I think we might need to check on that because they were quite clear in their presentation that they believe that the town council maintained it, but
yes, I did some checking and the town are certain it's the boroughs, and I know I've spoken to Bernie about it before.
Okay, thank you very much for that, Rachel. I think one of the important things that we raised was that there was no signposting to it. So our residents aren't aware it's there. So we need to make sure that happens. Any other comments? In which case, are you happy to raise your hand once to confirm both sets of minutes? Thank you very much. Okay. Are there any declarations of interest? No. Thank you. Do we have any public questions? No. And do we have any member questions? Right. Moving to the first item on the agenda, it's number 62, an update from South Central Ambulance Service, and we're welcoming Mark Ainsworth and Kirsten Willis-Druitt. Hello, are you there?
Good evening. Yes, we are. Thank you.
Hello. Okay, so we have received the supplementary agenda item, which I hope members have all received and been able to have a good look at. Would you like to take it through us and then we'll ask some questions?
Yeah, did you want us to present our end or?
Yes, would you like to share your screen, because this is live broadcast on YouTube and available for members of the public to look at any time. It'll be far more meaningful if they're able to see what we're all talking about. Are you able to make that full screen?
There we go.
Thank you. Thank you very much.
Thank you. Thank you for having us along. I'm Mark Ainsworth. I'm the Director of Operations for South Central Ambulance Service. I'll take you through the first slides and I'll hand over to Kirsten, who is our Head of Operations for the area that Wokingham sits within. So we're going to go through some of the points you asked us to cover around what our current demand looks like, what our performance is, the impact of our hospitals, and then looking at what some of our challenges are as we go through the coming months. These slides might look a bit complicated, but I'll try and talk you through them. So looking at our 999 calls, looking at this top left-hand chart, there are three lines. The blue line is where we set our budgets as to using historical data where we felt our demand would be for the last 12 months. We then recalculate that every 5 weeks to look at what the demand is actually doing. And then that's the red line. The green line is the volume of calls we actually received. So looking at the middle 2 weeks of February, which is the last data set we've got on here, you can see that we were expecting around about 15,999 calls coming into our 2 emergency operations centres per week. we actually received 17,500 calls coming in. So far higher call demand coming into both those centres than we predicted. There's a number of reasons for that. One of them is that when the patients are waiting for an ambulance response, we don't give them an arrival time because that ambulance could be diverted off to another call. So obviously as patients are becoming worried or relatives becoming worried, they do ring back 999 as advised to ask for an update if the ambulance is on its way. So we've seen a higher number of those calls coming back in for patients who are very concerned. The chart below that is actually showing the number of incidents we physically respond to. Exactly the same principles. The red line is where the last sort of 5 weeks where we predicted it to be. The blue is where we set our budget at the start of the year, and the green is the actual. And you'll notice from this that our actual responses, so where we physically send an ambulance or a rapid response car to, is below where we said it would be at the start of the year. So we're responding to around about 10,500 calls per week. Comparing that to the 909 calls coming in, that was 15,500, just shows there's 5,000 calls there that we don't actually send an ambulance or a car to. Now, some of those calls will be dealt with through one of our clinicians in the emergency operations centres, where they will offer telephone advice or advise the public another route to access their care. But we are responding to around about 10,500 909 calls per week. Looking at our performance, there's 4 main targets. All the incidents are categorised as category 1, 2, 3 or 4. They're nationally set standards for all ambulance services. And for the category 1 call, we have a mean target of 7 minutes. And again, using our predictive modelling, the red line on here is where we thought we would be for our performance at the start of the year. So the 7-minute line is roughly, hopefully you can see where my mouse is, approximately here, and we end up at 7 minutes. The blue line is where we're actually delivering our performance at this current time. And you can see there, we're roughly at about 9 minutes compared to the 7-minute target. The other target for our category 1 calls is we have to be on scene at on the 90th percentile of those calls within 15 minutes. So through December and the early part of January, we were delivering that performance standard. But unfortunately, over the last few weeks, we have exceeded that response time to the category 1 calls. Similarly with our category 2 calls, we have 2 targets for this. The top left chart is our mean performance. So the target for that is 18 minutes. And unfortunately, we are exceeding that as well. And you can see here, we've got an upward trajectory of our performance deteriorating, with us taking around about 33 minutes to get to those patients who we should getting to within 18 minutes. The second target for the category 2 patients is 90th percentile within 40 minutes. And again, you can see here during December and the early part of January, we were very close to that mark, still exceeding it, but that has deteriorated again over the last few weeks. The next performance measure is category 3. So these patients, we have a 90th percentile target of 2 hours. And again, unfortunately, you can see here we are exceeding that by just over an hour to those patients, and again is an upward trajectory. So our performance on all measures is really challenged at this time, and I'll come on to show you the reasons for that.
Would you be able to summarise what category 1, category 2 and category 3 are?
I would do my best. So category 1 are patients who are in cardiac arrest, they are unconscious, or a patient who is uncontrollably fitting or not breathing, or somebody who has noisy breathing. And noisy breathing could be somebody who's unconscious, laid on their back, therefore they're swallowing their tongues, that can make the noise from their breathing. Those are the main categories of patients that fit into category 1, so they're our most serious. And they take their account for about 10 to 12% of our overall demand. Category 2 patients are patients suffering with chest pains, breathing difficulties, stroke, so medical emergencies, again, that require fairly urgent response to assess them. And they account for about 50 to 55% of our overall demand. So that's the biggest category of call. Category 3 calls are patients who are presenting with lower grade medical emergencies. So something like an abdominal pain, an isolated extremity fracture, so perhaps a fractured wrist or a fractured ankle, or somebody who's fallen with unknown injuries. That's about 30% of our demand. There is a further category 4 target, category 4 performance, and it's fairly low demand. It's about 5 or 6% of our demand, and they are patients who just require a face-to-face assessment for their medical needs. So it's not an emergency response. It would be a normal road speed response for us to go and assess those patients. On top of the emergency calls, obviously we do take in GP admissions. So when a GP contacts us to take a patient into a ward or into the emergency department for further assessment, and again, we have time periods that we need to meet that target for the GPs of between 1 and 3 hours to collect those patients.
That's great. Thank you.
So just to show you what our significant challenge is at the minute, these are the same principles as the performance and demand charts. This is the level of hours that we were planning to deploy across the South Central Ambulance region. So if I look particularly at week commencing the 14th of February, we should have deployed out 53,000 hours of ambulance cover across our region. Unfortunately, because of staff absence levels, both through normal sickness and a number of staff off with COVID symptoms or isolating because of family members, combined with a lower recruitment level during COVID, we're around about 5,000 hours a week short of the cover that we need to meet the demand that we planned for. So that is costing us a significant amount of time to get to those patients in a timely way. This top chart is showing you overall for South Central. We then split the trust into North and South. The South is predominantly Hampshire, and the North is the Thames Valley, so Berkshire, Oxford, Buckinghamshire, and it does include Milton Keynes within that area. So you can see the 5,000 hours gap in the North, covering the Thames Valley area, is fairly consistent with what we experience in the South as well. One of the other challenges we have is our hospitals. So each patient that is conveyed to hospital, we have a target of 15 minutes to hand those patients over to the receiving hospital for them to take on their care. And that releases the ambulance back into the community to respond to the next 909 call. The top chart is showing you the time. So every patient has 15 minutes. This is every minute past that 15 minutes, the time that we lost whilst we were waiting to hand over those patients to the hospital. So in November, for example, which is the highest peak you can see there, we lost 511 operational hours outside of Royal Berks whilst we were waiting to offload those patients. We have over the last 3 months seen improvement from that, and we're down to 287 hours in February. Similar picture with Frimley Park Hospital. Obviously, some of the patients from the Wokingham area, so south of Sandhurst, Crowthorne, they will get conveyed into Frimley Park Hospital. And you can see again, September was the highest month there at 156 hours, but in February that was down at 53 hours. One of the measures the government look at is the number of ambulance handover delays that take place over 1 hour. And I really do apologise because lots of numbers. We do like our statistics in South Central. So this is by quarter. So we've got Q1, Q2 through to Q4. And what we're trying to show here is the number of handovers of patients that took greater than 60 minutes. So during Q4, we have seen just over 240 patients that have taken over 1 hour to hand over when we've arrived at Royal Berkshire Hospital. And as you can see through the numbers, that is an improving picture from what we experienced in Q3. Obviously, we're really concerned about our current performance. We have got a real focus on getting our recruitment numbers up to increase the number of staff, to reduce our sickness, but it is a national pressure. So I thought I'd just take the opportunity to share with you the national picture for the 10 English ambulance trusts. So the left-hand column is the name of the trust. Apologies for all abbreviations, but SCAS obviously in the yellow line, and then across the top is our performance measures for each one. And the number next to that performance measure is where we are nationally. So for our category 1, and again, this is for February, target was 7 minutes. We achieved 7 minutes 52. Only 2 trusts achieved the 7-minute target, and that's London Ambulance Service and North East Ambulance Service. We were third at 7 minutes 52, and the highest is South West Ambulance Service at 10 minutes 14. For our category 2, we were the best performing at 22 minutes 58. Again, remember that's an 18-minute target. For our category 2, 90th percentile, 40-minute target, we were first. Category 3, 90th, we were first. And our category 4, we were third. The last column here is looking at our 90th percentile for answering the 909 calls. Unfortunately, we are 8th in the country here, and this is due to a shortage of staff in both our emergency operations centres to answer the phone. So whilst acknowledging we are challenged with our performance and very concerned about having longer response times to patients against a national picture of high demand coming into the ambulance service and low staffing levels, we are doing very well at the minute with our performance to patients in our region. So I'm going to hand over to Kirsten at this point, and I'll carry on driving the slides on her behalf. Sorry, no, I'm doing these, aren't I? Sorry, Kirsten, my mistake. So just to go through, one of the items to cover off was looking at our recruitment. Just referring back to our call answer times where we're challenged, we have 2 call centres, one in Bicester and one in Winchester. We're really struggling with our recruitment in Bicester. It's an area of high employment with good salaries for the majority of people working around there. The call handler pay is fairly low. On NHS terms, it's only a band 3 pay scale. And we are seeing that we're struggling to fill vacancies in that area. So across both our control rooms now, we have offered a recruitment and retention premium to try and recruit more staff in. We're also working closely with the Isle of Wight Ambulance Service, and we've now appointed 15 call handlers that are working on the Isle of Wight in their control room to take 909 calls for SCAS. So there is an improving picture. We've currently got 100 whole-time equivalents, and we're working up to our requirement of 150, which we should be at by June. Looking at the operational shortages of staff, I'll show you on the next chart exactly where we're short of staff, but we are looking at how we can bring more paramedics into the region. And we're part of a Health Education England pilot to recruit Australian paramedics. We've got the plan for 48. Since sending these slides in, I can confirm we've got 42 after interviews which took place over the last week or so. So we've got 42 newly qualified paramedics who'll be joining us during the summer, working across the Thames Valley area. We're also looking at Eastern Europe, and obviously this project started before the invasion of the Ukraine, but we are looking at Poland and Finland to recruit paramedics from there to come across to the UK, and we're looking at doing that with London Ambulance Service. One of the challenges we do have is we are losing a lot of qualified paramedics to go and work for the primary care networks. So the primary care networks have received national funding to recruit paramedics to work in their surgeries or to carry out their home visiting services, and they get full funding for those staff. So they're offering out some very attractive salaries. It's predominantly Monday to Friday, daytime hours. And it looks very, very attractive for some of those paramedics to leave South Central and other ambulance services where they're working 24-hour shift patterns 7 days a week for less money. So we are seeing a number of our paramedics who unfortunately are experienced paramedics leaving to go and join those primary care networks. It's very good for the profession. Both Kirsten and I are both registered paramedics. So it's great as a paramedic to know that you can use your skills in other environments rather than just working on an ambulance. But it is costing us a lot of staff, and we're having to bring in new additional paramedics to retrain to get them up to their skill level. One of our other challenges is the high cost of living. So the Thames Valley area in particular, it's a national pay scale for our paramedics and our emergency care assistants. So as a trained paramedic, they'll be earning the same salary working in Manchester as they are in Wokingham, Reading, Newbury. So again, as staff qualify, they may train with us, but then a lot of them do go back to their own areas where they can afford to live and have a better standard of living they can around our area. What we need to do then is we have a gap. We know how many staff we need, we know how many we've got, and there is a gap. We use private ambulance companies to backfill that. All of those companies are registered with the Care Quality Commission. We have a contract with each of them to provide an ambulance and staff to the same level as what we provide. So if you called 999, apart from the badge on the staff member's shirt or on the side of the ambulance, you would receive the same level of care with the same level of equipment as if you had a South Central ambulance arrive. We're currently putting out about 9,000 hours per week using our private providers. And as we move through into the next financial year from April onwards, that increases to 15,000 hours. So that's to offset the gap that we have with our own staffing levels. And as our recruitment increases, we can then gradually reduce the level of private ambulance hours that are being provided. So just to show you where we are currently seeing our vacancies. So this is the north part of SCAS, and we split this area into 4. So we have north-south. So this is the area covering Wokingham through to Hungerford and Lambourne. Currently in the area, there's 40 vacancies for staff. Oxfordshire has 37, North Bucks and Milton Keynes 56, and our High Wycombe and Slough, Windsor Maidenhead area has 120. Obviously, this was a significant concern. So this area, around about half the operational hours that are deployed within this area are through private providers. Next year, we increase the staffing across, so from April, we increase the staffing requirement across the north-south area covering Newbury through to Wokingham, and we increase the number of vacancies. But as I said earlier, we do have a very active recruitment campaign to increase the number of clinicians coming in. We don't tend to struggle to recruit our emergency care assistants. They are staff who work alongside paramedics. And then that's a development route on to become a paramedic. What we do struggle with is the recruitment of the clinical staff, because they do need to go through a degree programme at an accredited university for 3 years prior to then coming out as a newly qualified paramedic. So at this point, I will hand over to Kirsten.
Thank you, Mark. Good evening, everybody. So moving on from what Mark was talking about earlier on with how the actual incidents are managed from a 909 operations perspective. So we split the way in which calls are handled, and they're dealt through these 4 different routes. So there's the hear and treat, which is by a clinician in our control room. So we have a clinical support desk, which is a cadre of a variety of different clinical qualifications. So it might be a nurse, it might be a paramedic, who are assessing the 999 calls and determining whether there is a need for us to actually attend. So that's what would be referred to as a hear and treat. So they've essentially managed that patient in the control room and either guided them as to treatment that's available to them, for example, in the community, or they may have referred them through to a community service. Roughly about 10% or so of patients are managed through that route. We then have those patients that are see and treat by clinician face to face with the patient. So that's those clinicians that have attended the scene of the 999 incident, but it's been deemed that after our assessment that they don't actually need to be conveyed to a hospital or a minor injuries unit, for example. And roughly 35 to 40% of those patients are managed through that route. So it's a full assessment that those patients receive prior to making that decision. The next group of, and probably the highest category actually, is those that we consider to be see, treat and convey. So those are the ones that a paramedic on an ambulance has gone out, made their assessment as they would have done for the see and treat, and then taken the decision that actually it would be most appropriate for that patient to be conveyed through to the emergency department, so that they can receive treatment for their injury or illness. And that's roughly, again, about 45%. And last but not least is what we call see and treat and convey to a non-ED location. So it's exactly the same. The clinicians made their assessment and they've taken the decision that they need to be conveyed. But what they try to do is access what we would refer to as an alternative care pathway. So that might be, and you'll see on a later slide, but it might be that they might be going to a cardiac care unit. They might be going to an ambulatory care unit. So referral direct through to the medics and medical consultants, or the surgical consultants, or we have other access pathways through for early pregnancy and such like. But that's about 5% on average that we would normally do. Thanks, Mark. So the top slide, very similar to what Mark was showing earlier on. So we're looking at the non-conveyance here. So we've got the measures that are being shown between the north and south. So as Mark referred to, the Thames Valley being the north and the south being primarily Hampshire, and how that gets split down across the areas. So we'll focus in on the north because that's where Wokingham falls under. So we are broken down into the northeast, north, south and northwest. And Wokingham sits in the north-south area, so that light blue turquoise line. And what you can see there is the hear and treat and the see and treat. So you can see that the average is roughly around about 45%. It's a fairly flat line. We did have a slight increase in those numbers, the percentages, in around September time, but on average, it's a fairly static situation. So nothing really sort of note from that perspective. The next one is what we call see, treat and convey to an ED only, so emergency department only. So that would be going through to the Royal Berks Emergency Department. Again, same colour for us, so that turquoise line that we're looking at. And again, you can see it's a very static picture. It has had a slight rise towards the early part of this year, and we are sort of at about 51–52%. Partly that's down to what we've been seeing is what we call the acuity of the patient, so how severe the patient condition is. And that's a reflection of the demand that Mark was talking about earlier around the category 1 and category 2 patients. And actually, if they are becoming more ill, then actually we would expect to see a higher conveyance rate and less of the access into other departments. And next is this non-conveyance. So this is to see and treat and convey, but to a non-ED, so a non-emergency department location. Again, this is a very low, and I mentioned it's only a few percent, so it's a very low number. Again, very similar to the other areas, except you will see that the top line is actually the northwest area. I probably need to explain that because it's a very different scenario, because they do a very different way of managing patients through an ED. So the Northwest will be covering the John Radcliffe Hospital, so a major trauma centre, and the Horton Hospital. And what happens there is that we have an awful lot of referral pathways that go through there that are not through the emergency department. So they have an extremely comprehensive ambulatory care unit and medical assessment unit. And they'll take direct referrals from paramedics in far larger numbers than the other areas do. And that's just down to how the setups have been, really. They've been extremely well engaged over the years and have been very engaged with how we can make those referrals. And in honesty, that's the way things should be, is avoiding going through an emergency department, ideally, if it's for a medically unwell person. Going direct to the department that they need to do is always going to be the most appropriate way in. However, you'll see from those other areas that we don't have the same pathways available to us as yet, but it is something that we are working on with the Royal Berks and with Frimley and with obviously the other areas within the other hospitals as well. Coming on to the impact that COVID has had on the ambulance service. So we have, obviously, Mark mentioned earlier on, we've had some number of challenges. The absence levels have been well above what we would have expected, and also what we have budgeted for. There's also been impacts around our estate and the capacity for operational basis due to the social distancing. Unlike the wider population that have obviously had the social distancing and COVID limiters sort of taken away, so the use of masks, etc., and it's public choice. That's not the same for the health service, so we still are required to wear our PPE, our personal protective equipment. That includes whilst we're on scene with patients, but also when we're in the cabs of ambulances, when we're on our stations. We can't sit in the same areas together. We can't be out on social standby points in the same way that we would have been before. So there's lots of challenges that come into that, which is affected on our estate as well. We have had delayed ambulance handovers at hospitals. This is a result of what they refer to as green and red patients. So a green would be we do ask what the status of a patient is. So if we're able to do lateral flow testing, or if they've had a PCR test done. If they have had a positive PCR test and on any patient, then those patients would obviously be deemed to be positive, symptomatic, and therefore they would have to go into a red area. And within the hospitals, they have designated wards that are either green or red. As COVID went up, and we're seeing similar things now, the numbers of patients being admitted to hospital who are classified as red patients has increased, which has meant that the available resource has been much decreased as far as bed occupancy has been available. That has obviously meant at the front door there's been delays in us actually getting into the hospital because there hasn't been movement through the emergency department. We've seen a detrimental impact onto the health and well-being of our staff who've worked and obviously under very high stress situations for an extended period. This has definitely taken a significant toll on the individual's mental health and well-being. We have done our absolute utmost to try and support people to stay well in the workplace, but their exposure rates have been obviously really quite high at times, which has been quite difficult. I think some of the significant things, if I bring in sort of a human factors aspect around it, is and for any of you who've had the unfortunate experience of having to see us in what I can only describe as an outfit that makes us look like we're going to the moon. We are in full face respirators. We are in a full Tyvek suit, so completely encased. And that's for those patients that are the category 1 patients that Mark referenced earlier on, trying to communicate with a family member to perhaps convey to them that maybe the patient has sadly passed away, or are really significantly ill or injured. It's really, really detrimental to the health and well-being of the staff member as well, because we don't have the same usual cues that we would normally use, so we're not able to communicate as anywhere near as effectively as we would have done. And that has been a big challenge, and it's certainly taken its toll on our staff. We'll move on to the next slide, please, Mark. Thank you. So the things that we've been doing to support, so we continue to work really closely with our colleagues from the community partners, as I mentioned earlier, utilising those pathways to avoid the conveyance to the acute trust emergency departments where we can. That might be through GP pathways, it might be through the UCRs, through the hubs and out of hours. So lots of different ways that we're trying to do that. We do have a dedicated team of urgent care pathway leads. So there is somebody that's allocated. He actually covers the Oxfordshire and Berkshire West area, so covering the Wokingham area. And they identify and implement those pathways and ensure that the staff are obviously using those community teams that were able to provide care to those patients as close to home as possible, which is always the ultimate aim, is having care in the right place. We continue to work closely with our whole system colleagues to have open dialogue with them. That's around getting those access pathways to see what we can do around the ED in particular. And if we're in times of extremis, then we do hold additional system calls to try and address what we can do collectively to ensure that we get the appropriate care for those patients in the right place. And lastly, our community responder colleagues. So those people that respond to our patients in a voluntary capacity, they have received essentially a first person on scene, a FREC course. And they've continued to work with us whilst we've been in the pandemic. So they received also the additional PPE and training that supported them to do that. And we do have active recruitment campaigns underway locally to bolster that team of volunteers, which is extremely successful and has actually been award winning as well. So thank you for your time this evening. We're obviously happy to take questions should they arise.
Thank you very much. Could I ask, what mitigation steps do you take when the service is overloaded? What is it you're able to do?
So there's a National Resource Escalation Action Plan, which is designed by the National Ambulance Resilience Unit, which gives us some direction around how we can increase our resources on the road. So as we get busier, we take more people from other functions and put them onto ambulances. So, for example, our education team, they will crew up on ambulances rather than teaching students or doing refreshers. Any manager who is a clinician would also be expected to respond normally in a car rather than ambulance. We've also been using the military. So during the first wave of the pandemic, we had 30 military personnel who are actually co-responders. So we train them to treat patients, but they work alongside a paramedic on the ambulance. We've still got 11 of those with us until the end of March. We've also worked closely with our fire services. We have had really good support from Hampshire Fire. Unfortunately, Berkshire Fire have had their own challenge with their staffing during COVID, so have had limited support from them. But again, bringing fire personnel in who have done a blue light driving course, we do an update with them to drive the ambulance, and they can work alongside our clinicians as well. We're also looking at how we can deploy our patient transport service. So these are the staff who take patients into their clinics at the hospital or transfer between hospitals. They've got some spare capacity at any point, then we deploy them out to convey non-emergency patients in, so GP admissions. On the day, when we experience demand. Like the hospitals have an OPAL framework around their level of escalation. We use that on the day as well. So at short notice during peak periods, normally in the evening, again, we'll issue messages out and we'll ask staff to make themselves available to come in and do overtime at work at short notice, or we'll deploy our first line managers, so our team leaders who are currently in the office, they go out and staff either rapid response cars or ambulances as well.
Well, that's certainly a whole wide range of extra steps you're able to take, which is very reassuring. I know other members have got questions. Let's begin with Jackie, then Sam, and then Rachel.
Yes, hello, good evening. That was a very, very interesting talk. About 6 weeks ago, I had to do a 999 call for my daughter, and I was surprised to see 3 people in the ambulance. Is that normal? Because years ago it was 2, but is that normal 3 now? So each ambulance is manned by 3 people?
We would normally have 2. The third person will be a student paramedic, so they're on their training. So during their 3-year course at university, which for this area is predominantly Oxford Brookes University, they do their clinical placements with the local ambulance service. So that would be why you might have seen they might have had on their epaulet sleeve on their shoulder a light blue epaulet rather than a dark green, which would indicate that they're a student.
We were worked up, so I didn't notice that.
But that's how we.
2 were older and 1 was younger, so that makes sense. Thanks. Thank you.
Okay, Sam.
Yeah, first of all, thank you so much for all the great work that you guys all do. I think we're very, very appreciative, and it was really great to see the trust rank so highly overall against many of the others across the country. I know there was one exception, but across the board, really positive to see, ranking very highly. My sort of question was based on is really the private ambulance services and the reliance of the, just really keen to understand a little bit more around, how are you finding using those services? Is it a positive? Are there any issues or differences you're finding when comparing them to your own ambulance services? And also, in terms of the budgetary constraints, how much of an issue is this, or how much of your budget is it eating up using those services?
So obviously the budget is a fairly significant concern, particularly when we're needing to increase from 9,000 to 15,000 hours a week. We do have that money available from our own staff vacancies, but obviously it's more expensive to bring a private ambulance company in and employ our own staff, because we're not just paying for the staff, we're paying for the ambulance and equipment that come with them as well, which unfortunately we've got ambulances that are not being used because we don't have the staff to operate on them. So it does work out slightly more expensive to bring in the private ambulance companies. We are very well assured on the quality of those staff. We have a department that looks after those private ambulance companies. They do clinical governance and operational governance inspections on them. They're expected to deliver to the same performance levels that the SCAS crews are. So they're assessed on their see and treat rates, their conveyance rates, their times that they spend with patients. So one of the things that we've seen during COVID is that we spend longer with each patient because of the personal protective equipment that we need to wear, and because we have to clean the ambulance after every single patient that goes in them. So we've actually spending 5 minutes longer with every patient than we were pre-COVID. So again, the private providers are measured on that standard as well to make sure they are compliant and they're on to the next patient as quickly as our own crews are. The crews that we have from them are currently required to provide a HCPC, so Healthcare Professional Council registered paramedic on each of those ambulances. From April, we will be using non-registered ambulances as well. So they will have either an ambulance technician, an associate ambulance practitioner, alongside emergency care assistant. So we'll be taking those in from the private provider companies as well. But the public really shouldn't notice any difference than a SCAS crew turning up.
Brilliant. Thank you for that explanation.
Thank you. Rachel.
Good evening. Thank you very much for the report, and thank you for everything that you've been doing during COVID in particular. I was wanting to ask you about some staffing questions. Going back the last few years, how have you seen your ability to get the numbers of staff change over time? Is it getting harder and harder progressively? Is it getting easier? Does it go up and down?
Are you on about the number of staff that we recruit into the organisation?
Yes, and the relative ease of doing that. Is it getting harder to recruit staff over the last, say, 5-10 years, would you say?
Yes, it's getting harder. We had a change in the academic requirements for paramedics. So we used to be able to train a paramedic within 12 months through a certificate of higher education course that was run at Oxford Brookes. That is no longer recognised by the Healthcare Professional Council for registration. So all paramedics have to now do the 3-year course. That obviously led to a period of time of 2 years where we struggled for recruiting paramedics. So that was 19, 20 and 18, 19. That was when we saw a significant drop in the number of paramedics coming in. We have this year introduced the Paramedic Apprenticeship. So that will enable us to take members of staff from either patient transport or the new member of staff joining us through the apprenticeship programme to become paramedic, which gives us another route for increasing the staffing numbers. As I said in the presentation, that the numbers of staff coming in is fairly consistent. It's the number of staff that's leaving us that's the concern, because that is on the rise. So that means we are needing to increase our recruitment by about 20% to offset the number of staff that are leaving whilst filling the vacancies that I showed you in the presentation. So if you're asking us what our number one challenge is, it is getting enough staff out on the ambulances through increasing our recruitment and trying to slow our attrition and trying to keep the people we do train in the organisation.
Okay, thank you. Thank you very much. And I was wondering as well, I mean, you were saying that you're having to spend considerable amounts of money on private ambulances, and you are also losing staff because of the national pay scale. I'm wondering what steps, if any, we're able to take to get that national pay scale revisited so that there is, for example, some kind of Thames Valley weighting.
There is a review underway at the minute nationally of all ambulance service roles to look at the pay scale. So we're waiting for the outcome for that. The paramedic pay scale changed, I think it was about 3 years ago now. They increased a pay scale. So a qualified paramedic is now a band 6. London weighting, Bracknell and Wexham Ambulance Station both receive 5% high cost living allowance. We don't see that attracts people in because it's still a very expensive area to live compared to if they were perhaps working in Stoke Mandeville, for example, in Buckinghamshire. It's a cheaper area for them to buy a house. We have applied a recruitment and retention premium to High Wycombe. So if you refer back to the map I showed where we had that large number of vacancies, we have offered an extra joining payment and retention payment after 2 years of employment to try and attract people into that area. That only started last year. We have seen 40 additional staff join that area in the last 12 months. But obviously to see the effectiveness of the retention payment, we've got to wait another year to see if staff stay for the full 2 years. What we are hoping is that the National Pay Review will identify that the lower paid bands, so the emergency care assistant at band 3 and the technician at band 4, during the review of those, we're hoping that they do increase the pay conditions for those groups of staff.
Super, thank you very much.
Members, do we have any other questions? No? Okay. We really appreciate you coming along tonight. We know that you and all of the staff of SCAS, as you say it, I've been saying SCAC all week in my head, but SCAS. So please do pass on our huge thanks. And what I think we all want to know is what could Woking Borough Council be doing to help? Is there any messages that we can help, or is it anything more solid that we might be able to do?
I think the main thing would be, helping us with the promotion of use of appropriate services. So you'll notice when we're under immense pressure, we often use social media and the media to talk about appropriate use of the 999 service. So any messaging around use of primary care, use of pharmacy, 111 online, so all those other services prior to calling 999. They'd be the main support that we ask from everybody, is just to ensure we use the 999 service for the appropriate, sort of serious emergencies. When somebody does call 999, we do tell them there will, if there's not a category 1 or category 2, we do inform them that there will be a delay in our response, and we do offer them to make their own way to the hospital. That's not always possible. So any demand that we can take out the 999 service will help us get to those life-threatening calls that bit quicker.
Do you work with other entities such as voluntary organisations? I know that was one of the questions that Adrian had wanted to highlight tonight. The voluntary organisations that provide patient transport. So are you able to refer to them or suggest people contact them?
We don't directly refer to voluntary societies for transport. But we do work with local authority and health providers that can go out and see patients on our behalf. So the clinicians that are working in our emergency operations centre, they know which clinicians are available with which provider or which home care service is available, and they can refer those patients directly to them, as can the ambulance staff that arrive on the scene. They have access to something called the Directory of Service. So that's an electronic database that shows all the services within the area they're working. So if there is, for example, to pick a patient who's got a blocked catheter, they don't need to go to hospital for that. They'll be able to look on the Directory of Service and be able to see which district nurse is available to come out and treat that patient at home and pass the care on to that district nurse.
Okay, thank you. So thank you very much again. We'd just like to make sure we record in the minutes our huge thanks to you both for attending and for everybody at SCAS.
Thanks very much. Thanks for having us.
Yeah. Next item on our agenda is 63, Adult Social Care Key Performance Indicators. I believe we're welcoming Simon Broad. Are you with us, Simon? I think Lewis is here as well.
I'm with you.
So we're looking at page 19 to 26 in the agenda. So Q3 of 21, that is a while ago now, isn't it?
Yeah. Sorry, I'm just I haven't got the papers in front. I've got the data in front of me, but I haven't got the papers. I'm standing in for Matt tonight. Matt Pope.
Okay, are we going to get this on screen? I think Madeline is going to do this.
I think Charles has got his hand up.
Yeah, go ahead, Charles.
Alison, I was going to say, I've got the data in front of me, so if you want me to do a brief overview and then Simon answer any detailed questions, I'm happy to do that.
Okay, well, we're happy to hear from whoever would like to confidently take this through and be able to answer all our questions.
I'll try, but Simon's there if I can't. If you're happy with that, Simon, that is.
Yeah, I'm happy with that. Thank you.
Okay, so Madeline has emailed Simon so that he'll be able to put it on screen. Because as we were remembering earlier, this is a live broadcast and recorded, and it's going to be a lot more meaningful for the residents to be able to see what we're talking about. But if you want to begin with talking about the wins and the opportunities.
Okay, well, basically, I mean, the first thing I was going to say was and apologies if I'm repeating something I said at previous meetings, is that our KPIs are all, there's a large amount here of stretch targets because we're trying to raise the performance of the department. So as I go through each of these 8, you'll see there are some where we're above the national average, basically, but seen as not hitting the target. And I just wanted to set kind of a tone behind that. So, Madeline, if you don't mind going to the first of the KPIs, please, which is A1. Keep going for me, please, so because I'll talk to it. That's perfect, thank you. So the first one, social work assessments allocated to commence within 7 days of requests. We have had a drop-off in performance over the last couple of quarters. We've had a particular issue with increase in the complexity of cases, and steps are being taken to rectify that, including more recruitment and a lot of efforts to increase retention. I would say, however, the key point to bring out is this target is a stretch target. We're trying to commence within 7 days of requests, but the national figure as you can see on there, is 12% of people waiting a social work assessment or nationally are waiting more than 6 months, and 93% of assessments in Wokingham are completed within the time frame of 28 days. So whereas this is, obviously performance is slipping and efforts are being made to improve it, we're still performing well above the national average. The second one on there, which is shows continual improvement, is reablement from the start team following discharge from hospital, which is a credit to the staff who were involved with that. Madeline, if I can have the next slide, please. Safeguarding continues to improve. That step back in 2019-20, that big increase in performance, basically, that you can see there, was when we bought these services back from Optalis and bought them in the house. And you can see in there the seasonal trend that comes through, basically, with this. But we're on target and maintaining the level of performance that we have done for the last 2 years. Number of people, AS7, proportion of people receiving long-term care who are subject to review in 12 months. This is another stretch target. We're actually third in the southeast in terms of performance here. So obviously because of that, we're showing as red. There's been a small improvement over time here, and the aim is to keep basically driving upwards and actually reach that target. Next slide, please, Madeline. AS11, so amber. Oh, sorry, AS9 actually. So 2 green ones here, permanent admissions to residential and nursing care homes per 100k of population. Obviously, if we're trying to look after the well-being of our residents, it's better to maintain them at home for as long as possible. So the fact that graph is going down and is now well below the target is great news. And percentage of referrals basically on there, again, another on target achievement there. So AS11, please, Madeline. Percentage of people who receive direct payments, we're literally a fraction off the target. We've slipped back 1%, and this is another stretch target. We're currently third highest in the region for this performance. So we want to get better. We want ambitious for performance. That's why things are set out this way. But happy to take any questions, and those I can't answer, Simon's obviously here.
Sam, do you have a question?
Thank you, Chair. Thank you, Charles. It was really, really useful going through that. My question was in regards to page 23, AS7. Really great to hear that the performance is in the top quartile in comparison to other local authorities. It says that the sort of aim is to potentially, improve this even further. Just wanted to see what the plan was to do this and to aim to become the top quartile, really.
I think I would say on a broad kind of top level, basically, we're trying to raise the performance of the department into the top 25% in the country on all measures. And that's the logic of setting these stretch targets. Simon, if you don't mind taking the detailed level below that, please.
Yeah, it's AS7 is the proportion of people receiving long-term care who are subject to review in the last 12 months. I think our reviewing team, we have a statutory responsibility to review everyone on our books, if you like, who is receiving a care service. We're aiming towards our 85% target. But equally, the review team needs to respond to care quality concerns. So, for instance, we've got a quality concern within a care home at the moment within Wokingham, which is being inspected by the Care Quality Commission, and who've they've raised some issues which we already knew about, and so they agree with the concerns that we raised, which meant that the reviewing team have had to undertake a number of unplanned reviews for all of those people that live in that care home. So whilst we have a plan and we proportionately review people depending on what level of service they're receiving, so if people have got severe complex needs who may be placed out of borough in a specialist care home, we may spend quite a long time reviewing those, but a more proportionate review would be for someone who's attending a day service 3 days a week. So whilst we've got a program of plan reviews, and we work with our performance team to understand what number of reviews we need to undertake per month or per week and per month, and what resource we need, we also need to take into account the unplanned reviews and the reviews that are needed to be undertaken, which we don't know what's coming, because we only know when a care provider breaks down or there's an emergency in a particular provider. We're going to have to send our reviewers out there. So I think what I'd like to point out to the Health and Overview Scrutiny Committee is that the stretch target for the number of reviews per annum needs to be balanced with the number of unplanned reviews and how we're dealing with situations that come along in a way which are unplanned and unforeseen.
Brilliant. Thanks, Charles. Thanks, Simon.
Okay. Generally at this committee, when people come to talk to us about their performance, they normally have a lot to say to us about the problems of staff retention and recruitment. Your targets don't, well, I suppose they're all impacted by that. So I just wondered if you could tell us the situation at Woking Borough Council currently with your social workers and other officers.
Do you want me to go for that one?
Yeah, that's probably better if you do that one, Simon.
I think whenever we produce or present performance, you have to strike the balance between what I feel as an operational manager are the real reasons, but I don't want to make excuses at the same time. But of course, we do have a real problem with recruitment of occupational therapists nationally and locally, and social workers. There's a number of mitigating actions we're taking to improve that. So we're in the process of developing our workforce development strategy. We've just upgraded or reviewed our website and our recruitment websites. We've filmed a number of different practitioners from occupational therapy, technology-enabled care. I think Matt Pope has done a video as well. So we've completely upgraded and modernised our recruitment website. We're trying to be more competitive in the market because we're competing with neighbouring authorities and London boroughs for the same pool of staff. We've started to advertise on radio, and we're looking to advertise on some local other local media outlets, including LinkedIn and WhatsApp and various other. It's not WhatsApp, it's LinkedIn mostly. But we're looking at a range of different methods of how to improve the chances or the opportunities or the reasons why people want to come and work in Wokingham. So one of those kind of drivers is the fact that we want to be, as Charles says, in the top 25% of all adult social care departments in the country, and that is one way of recruiting staff, as well as paying them, as well as good terms and conditions. It's actually come and work for a forward-thinking authority, and that's our ambition to do that.
I think all I would add to that, Alison, is in reference to what Simon just said. If you look at any of the videos that have been done, the message that in them very clearly is the quality of experience of the job, of the training and support that you get within Woking Borough Council in adult services department, the support from managers and the career structures, etc., because they are benefits we can sell. I think the other thing I would say, it would be very easy for myself or Simon or Matt to sit here and say basically, oh yes, well we didn't hit that target and that's because the market's difficult, basically, and all of those things. And I'm not going to deny there are some significant challenges, but we don't believe in making excuses or using that, and we're trying to be proactive and trying to find ways around that.
Yeah. I think I can speak for the members that, you know, we can see from the targets and the achievements and what you're doing that, you know, you've been thinking, you know, beyond what's been done before to make sure we can hit that to be in the top 25%. Just to go back to Simon was saying about, you know, new ways of recruiting and going onto the radio. We heard tonight that we're looking to recruit paramedics from Australia. At the last meeting, we heard that the Royal Berks are looking to recruit midwives from, was it India? You know, and we know in the past that we've had social workers for children's services. They were recruiting in Australia as well, but I'm not sure that worked out that well. So are you looking beyond the UK to try and recruit occupational therapists and social workers?
I think there's two parts to our workforce, which one can't work without the other. So I think where we have support, we've supported our provider market with trying to recruit overseas. So using part of the government's workforce development grant, we've helped care homes and domiciliary care providers. If we don't have our domiciliary care providers or our care home market, then we're unable to commission services. So, you know, I think that our efforts have gone into helping our provider market to recruit the sorely needed staff that they need to carry on operating and working together with us. So I think our focus in terms of overseas has been with our provider market as opposed to social workers internally. Lewis.
Lewis, would you like to add to that?
Sorry, Chair, jumping in. Absolutely. We've been working on our workforce strategy across the borough, which would include our provider networks, as Simon's elaborated on, and we have various schemes which I'm unable to recall at this given moment, but various ideas and schemes for ensuring that we do have the appropriate volume of occupational therapists and social workers in the borough, working to make sure that we're up to snuff, up to scratch, got the right number of folk in post. But just to sort of say on that note, we are in National Social Worker Week this week. And if any of you are similar to myself and follow the council on Twitter, Facebook, LinkedIn, you'll see the various messages that have gone out to show how we're doing. And I think the point which Simon has been a bit humble in making is that what makes Wokingham such an attractive place is the innovative way in which we work, but also the hygiene factors for our social work teams. So supporting them to have manageable caseloads, and ensuring that they're not overworked, overstressed, etc., which is what is paying dividends for us to ensure that we are recruiting successfully and getting posts in. And also the innovative work. So, for instance, our MDT social workers, our primary care network social workers, which are going to be joining us at the end of this month. One of the first place I'm aware of in the country to do that sort of work. And the fantastic work that we do across integration with our primary care networks and our partners across the system makes Wokingham an innovative and an interesting place to work, which is why we're doing okay.
I think I wanted to touch on something that you said at the beginning of your question, Alison, which was the amount of targets and KPIs. You know, I've raised with the leader, the deputy leader, and the member responsible for KPIs. We have 8 KPIs. We could have more, because we're serious about improving performance. I look at, for example, highways who've got 2, an environment who've got 2, basically, and it would be very easy for us to sit and produce a sheet of green every quarter, basically, but we're actually interested in doing the job properly, basically. So, you know, that's why we get to that place. And I think, you know, the council as a whole does have to have a serious, not perhaps for POST, but does need to think about KPIs and what's the point of them, basically, and what we're actually trying to achieve from this exercise.
It is new for POST to be looking at these. I believe in the past they went to the audit committee, but this seemed a more natural home for it. Yeah, I mean, we certainly don't want to be having officers taken away from directly, you know, improving care for our residents to be preparing papers for this meeting. But I believe we haven't actually looked at it each time because we were understanding of the pressure on you with all of the developing issues of COVID throughout the last year. But so thank you very much for coming along tonight. Unless anybody's got a question that's come to them and
I
following
think
the
Simon
recent
wants to say
conversation?
something, Chairman.
Oh, Simon.
Yeah, I just wanted to add a bit of context in the time period we're talking about. Is one of the one of the pieces of work we're very proud of, which is included in these KPIs, is the effectiveness and the way in which we have helped discharge people from hospital in a timely way and consistently outperformed all of our neighbours over a 12-month period, 18-month period, in terms of supporting the RBH and health colleagues in enabling the hospital to be the patient flow throughout hospital to be as effective and efficient as possible. And I think Wokingham has played a significant role in making sure that our numbers are lower than our neighbours. Not that it's a competition, but we have done particularly well. And that's not included in this set of performance indicators, but I just wanted to mention that that's part of the context, and supporting our care home market, which I think we've been one of the best performing councils in the country in terms of really supporting our care home market, even going against government guidance back in the early days of the pandemic.
Hear, hear.
So we may see significantly increasing numbers of people moving here to retire to take advantage of the very high standard of adult social care we provide. I'm not sure that would be a win completely. But I think I can certainly see why somebody would choose to retire to Wokingham. Not only a beautiful environment, but also an excellent standard of social care. So thank you very much, gentlemen. We're going to move to the next item on our agenda. I believe, Simon, are you staying with us to present that? We're going to be looking at an update on the Healthwatch report regarding carers in Wokingham Borough. And I think we're welcoming Pamela Iyer as well. So members, that's on page 27.
I think Pamela's going to present, and I'm going to chip in where needed.
Hello, yes. Good evening. Would it help, Chair, if I put the slides on the screen?
Yes, please.
Can you all see them?
Yes.
Yes, we can. Thank you.
Okay, lovely. So I'm Pamela Iyer. I'm Senior Commissioner in the Strategy and Commissioning team, and I'm here to present Adult Social Care's response to the Healthwatch report that came out regarding the state of caring for unpaid carers during the COVID pandemic. First of all, I think we'd like to thank Healthwatch for this report and for highlighting the concerns in question. So as brief headlines from the report, Healthwatch Wokingham surveyed unpaid carers about their experiences of caring during the pandemic, and the report was published in the autumn. 89 carers completed the questionnaire. In Wokingham Borough, we have approximately 14,000 carers as of the last census, while we wait for the current census to be published. So this represents a sample of carers who are quite well engaged and have regular contact with Wokingham Borough Council services and with our carer services. So the top concerns that were reported by carers include decline of the person that they care for. So this quite often included a physical decline, as people weren't able to go out and exercise, but it also included a decline in mental health, in emotional well-being. For people who cared for someone with dementia, this also often included a decline in their understanding, as the restrictions that were in place for everybody weren't always able to be understood. Understandably, for unpaid carers, 78% of those responded said that the hours of care that they provided had increased. I think a particular note in the report was carers where they themselves were either a young carer or a parent carer. Obviously, the schools were closed for quite a long time during lockdown, and this had a commensurate effect on family life for many, specifically where there is a caring situation involved. I think that really made a significant impact. So the negative effect on mental health, physical health and family well-being is recorded at the bottom of the slide. So in terms of other findings, one positive was that carers found it easier to get food and medicine thanks to the Wokingham Borough Council community response that was coordinated via our One Front Door initiative. We also saw in the report that direct payment recipients reported some inflexibility and delays over responding to questions and concerns, which we are addressing in a direct payment review. Out of the respondents, 2 out of 3 respondents didn't know their rights as a carer, so they were surveyed about specific things in the Care Act, including the right to an assessment. 30% didn't know what a carer assessment was, and 40% weren't registered as a carer with their GP. So on the first slide, I mentioned that this was a quite engaged group of carers. So I think we'd all agree that for 30% of those carers not to know what a carer's assessment is, and I think in fact only 30% of that group had had a carer's assessment, that's not really acceptable to us. So having read the report, we reviewed the recommendations and we looked at areas going on within our strategy and where we could take actions to strengthen and prioritise those. So there was a recommendation to identify hidden carers and increase the amount of support. So this aligns with our carer strategy priority 1, identifying and recognising carers. And I think as a result of the report, it's important that we note that we include seldom heard and hidden carers in that. So we have commissioned a Keeping in Touch project, and that is going to run for 12 months initially, and that is going to provide anticipatory care to carers, and by that I mean it contacts carers ahead of any escalation in their circumstances. Because we're doing a large number of calls, and I think something like 1,200 calls were completed by Woking Borough Council in January and February to carers, we've also taken the opportunity to do a data validity exercise. So we're going to make sure that we know who all our carers are. Where people have sadly died, we will remove those carers from the database. The next priority was put in as a Healthwatch own priority, but I think it's important to note that in terms of improving GP surgery support, this is something we've been doing through our integration work with primary care networks. It includes things like making sure that there's a link on GP websites that directly links to up-to-date carers information. In terms of increasing information and support to known carers, we have been developing a co-production customer engagement toolkit, and this is going to enable greater involvement of carers. We have been piloting this through a recent commissioning exercise in November. When we recommissioned the carer services, we had current carers and former carers give their input on the service and also the submissions that were evaluated as part of a valid tender. We are also currently reviewing our community directory, and Project Joy, which is an online platform allowing service users to connect with services, is being recommissioned. We have also asked our carers provider Toolkit to undertake Care Act training and service improvement. That is all ongoing at present. The next recommendation was to continue what worked well during the COVID period, and this really mapped to all our strategy priorities, all 4 of them we felt. We reviewed Wokingham's community response, again engaging in the welfare calls. The work is ongoing around this. I think we've all got lessons to learn around many aspects of the pandemic, and we are doing this in terms of continuing improvement. For example, with our commissioned carer services, we're meeting them weekly to update on the carer situation and look at how the services can continue to improve. The last set of recommendations include Woking Borough Council publishing written guidance for direct payment recipients who couldn't spend their payments normally. And what that means is that as a result of the restrictions, those people who would normally have spent it on social or cultural and leisure trips that they were no longer able to undertake, that there would be guidance for how they could spend it otherwise. We are commissioning a review on direct payments, and we're looking at strengthening current practice. Within the carer strategy itself, there are going to be various work streams, one of which will look at this as well. The next recommendation was to prioritise provision and take-up of respite options. So carer respite is already considered in care planning. We have also, in the recent procurement in November, reconsidered how we structure our respite services. So there were previously 2 separate services running, and those have now been repackaged into one service, which allows for economies of scale. We are looking at the clinical commissioning group's updates to carers information on GP websites, which I spoke about before. Our carers lead has completed that work with the correlating lead in the CCG. And our final priority recommendation was to end the disparity between the number of carers registered with the GP and the number of carers registered with Woking Borough Council. And I think I would add to that probably the disparity between the census numbers of carers and those that we know about. So I think we have made significant progress on this, with 1,200 calls being made in January, February, 83 new referrals as a result of that so far to our carer services, and a continuing data validity exercise that will take place in June. So that is the end of the slideshow from me, and I'm happy to take any questions, and Simon and Lewis are here if I can't answer them.
Okay, well, thank you very much, Pamela. I know that, if I echo it, I know that we all welcome the recommendations that Healthwatch presented to us at this meeting, because the carers that we have here in the borough, they're doing such an essential role. You know, the unpaid care that they provide is often, you know, relentless. And we certainly want all of those carers to be better identified and supported. And we want them to have a better quality of life. You know, this needs to be a borough where our carers are safe, they're well supported, we value them, and, you know, we give them that essential recognition of their unpaid key worker role in our community. So thank you for everything that you've done going through. You've explained how you're going to identify them and work, particularly to work with our GP practices, because I think that's essential. What would you identify as your greatest challenge in being able to implement all of the recommendations?
I suspect Simon and Lewis will want to add to this, but I think from my point of view, as a strategic commissioner, I think the biggest challenge at the moment, as well as the remote nature of most of our working, is how our commission provider works on the ground. And I mentioned that we're going into service improvement with them. We are looking at how they work strategically with voluntary and community sector services throughout the borough. And we're also looking at our kind of statistical neighbours and looking at whether what we pay for those services is fair, reasonable and equitable, and whether we can expect there to be the service that we want for all of our carers as a result. I think that really identifying carers is difficult because we have a lot of people who are very proud of their caring role. And I think it's important to note that actually being a carer, as I've been myself, has some positives as well as negatives. And in our approach to identifying carers, it's really important that we demonstrate an understanding of that. I don't know if Simon and Lewis want to jump in.
Yeah, sure.
Okay, Simon, do you want to add to that?
I was on mute, I'm afraid. I think in answer to your question, from my perspective, one of the key things that I'd like to see happen is for carers across the borough to understand, either via the website, either via through their GP surgeries or leaflets or in libraries, exactly what their rights are, what they're entitled to, and where they can go to ask for help. And I think, when part of my role is to speak to people who have complained about various aspects of adult social care. And I end up having long 45-minute conversations with carers about a whole range of topics, whether it's national government policy or the woes, the shortcomings, the perceived shortcomings of adult social care. But what I find having those conversations is that they find out so much more. And obviously, we can't have a conversation with every single carer when I'm answering complaints. But I think that the message I'm getting from these conversations is that they don't know enough. So how can we as a council ensure through our website, through leafleting, through our NHS partners and other partners in the voluntary sector, provide information and advice and guidance and support and signposting and in the right places at the right time when people need it. So for me, that's the main challenge. I don't know if you want to add anything, Lewis.
Absolutely. Ever being the solution-focused project program manager that I am, just to sort of pick up on a few points here. So with regards to the piece here, so carers is going to form, hopefully, we haven't had it formally agreed, and when it is, we will be taking it to our Wellbeing board. Early stages, carers are one of the priorities for our integration board this year, which is made up of our partners across the voluntary sector, adult social care, our primary care network GPs, BHFT, our nursing provider, RBH, Uncle Tom Cobley and all. So we'll be looking at ensuring that we're trying to support carers where we can. The important bit here is to do that, encouraging people to sign up, is to give a good offer. So if we're able to explain very clearly what it is that we can offer our carers in terms of what benefits there is by self-identification, which is one of the things we're going to be working on this year, people are more likely to sign up and identify themselves, so that way we can get them better support and guidance. As sort of previously discussed, we've already started the process of doing our joined up work with our GP, CCG and voluntary sector colleagues. So there's some stuff that's gone onto websites, various different pieces there, and obviously the mention of Joy there, which has been recommissioned for the next 3 years, as we're working on that at the moment, hopefully. And just to draw together the experience and knowledge from all of our voluntary sector colleagues from the various schemes that we're supporting across the borough. So very often our carers are exposed to our voluntary sector often before they are exposed to the council, and potentially second only after our GPs. So ensuring that our social prescribers, community navigators, and our various different sort of alliances like our Mental Health Alliance and our Friendship Alliance to support with social isolation are all up to speed to make sure that we are advising and guiding people towards that self-identification process so we can get the best outcome for them.
Sorry, just one more thing to add, Chair, is that I think carers have a huge amount to offer, not just in the normal ways in terms of caring for someone they love, but it's also in contributing to how we recruit, how we shape policy, how we. So I'm really interested in adult social care, and I think it's wider across the council as well, about not just customer engagement, but co-production. So it's how do we use carers and users of services to start to work, not consult with them, but to work with us, in a real way to help shape policy and deliver and implement policy and strategy, because they, at the end of the day, are our customers, our residents, our citizens. So I think as we're moving forward, there's going to be a far greater role, and we're encouraging this and trying to facilitate that, in involving carers in shaping procurement, policy, recruitment, a range of things. So I think that's work in progress, which we're really keen to progress further.
Okay. We do have with us on Teams Jim Stockley from Healthwatch, who put forward these original recommendations. Jim, would you like to? Have you got any comments or extra questions?
Yeah, I mean, first of all, what I would like to say is that I think Healthwatch would like to recognise the reaction from from the council and council officers to this report, and the fact that genuine positive steps are being made, and I think we should all applaud that. Also, again, Berkshire West CCG as well on this whole area of GP websites and access to information, and made a number of commitments about what they're going to do differently. If I could just quote from one or two of these, which actually came from Andrew Price, I think at the beginning of the month, they're proposing that each practice has core information. They can supplement this with anything that's local and appropriate. And it was things like register as a carer with your GP. I think, is it Tavida provide local support? Woking Borough Council is also a reference. You know, when all else fails, sometimes go to the council. Woking Wellbeing Service, even ourselves as Healthwatch, Carers Direct Helpline, which is a national body. But I think, as all the speakers, previous speakers have said, and I think I know we all said, what's your biggest challenge about this, that? I think my biggest challenge across any area of health and social care is usually communication and access to information. And I think certainly in respect of this particular report from Healthwatch, which was obviously, you know, got that reaction, I think it's a really good step along you know, along the way. And I think we all have the same good intentions as well. So thank you for that.
Okay, so yes, thank you very much. And we're going to move on to the next item on the agenda, which is item 65, an update on the work of Healthwatch Woking Borough. Are you presenting that, Jim?
Well, yes. First of all, apologies. Nick Derman is on holiday, which is more than well deserved. And Joanna, who is also a Healthwatch officer, but she's part-time, she's not available. So I'll just talk to this in 1 or 2 areas. First of all, work of Healthwatch, we are currently working, or rather the team and its management are working towards the transfer to a new provider for Healthwatch. And that becomes effective at the end of this month. So there is a fair amount of effort is going into that at the moment to ensure there's a seamless transition. So as I say, that pretty much is ongoing. Our annual report will be completed, although it doesn't get published until June. The HOSC, I think, hears pretty well everything that we're doing as we go along, but the wrapping up of the whole thing into a view on the past year won't be around until June. Our GP access report is published by the end of this month. And the comment I have from Nick is there's lots of interesting data, but I suspect some of the access issues are fairly well known anyway. Few things that we're actually hearing as Healthwatch, and I suspect no surprises because I think we hear our councillors as well bringing this up. Dentistry is still being very challenging. Many can't get an NHS dentist, as we know, and their issues are becoming more severe. We actually heard from somebody who'd been given an appointment for an urgent dental procedure in another part of the country, but actually had no money to pay for the travel. So there's a bit of a problem there. And another who needed a tooth removed at the RBH and inpatient hospital care because of an infection that developed after she was unable to get an appointment. I don't think these situations are unique, and we know that dentistry as a whole has been a challenge, and certainly access to NHS dentists are. But Healthwatch, looking forward, irrespective of who's responsible for running Healthwatch Woking, will very definitely need to be looking at this area over the next 12 months or so. In truth, as I say, there's not much more to add about what's going on in Healthwatch. You will hear, I'm sure, from Nick. I trust you will next month. I was just checking through my notes. There's not much more to add to that, which hasn't already been reported. I think you've already had the Aging Well report as well.
That's the one we've got in front of us tonight. HOSC won't be meeting now until June. Is that right, Madeline? Yeah. Okay.
So, I mean, if I can just summarise from my side, I'll take any other questions in a minute. As you know, I've been involved with Healthwatch since its inception, which means we're coming up 9 years. So it's going to bring a close for me, and we trust but we've worked pretty well to make the voice of our community well heard. On a particular note, I would like to say we've always regarded as the HOSC as a really important chamber to hear our information work. And I do know that myself and board would like to say what a pleasure it's been to be involved with all the councillors who sit on the HOSC. And thank you for your support and wish everybody every good success. I'm sure there'll be some familiar faces reappear, but obviously it's going through a TUPE process at the moment and I can't comment on it, and it'll be up to the individuals, but I hope very much that they continue to appear, and we wish our successors every good luck. I'll take any questions about anything.
Members, any questions for Jim on Healthwatch generally or specifically on the Ageing Well report? Sam.
Thank you, Chair. It was more just a comment, just to say thank you for all your support over the last 9 years. I mean, it's incredible what Healthwatch has done, and regardless of what happens moving forward, just want to say thank you from all of us on the committee.
No, as I say, it's truly been a pleasure.
Yes, I can certainly echo that, although I was going to let the members ask questions and then summarise to thank you very much for coming tonight and all your contributions, Nick as well. And I know you've got a whole team of people who work very hard because they really care about ensuring that all of our residents from, cradle to grave have the best care, support, and you're that a strong voice that can speak up, but also I think it's often pulling all the threads together to sort of be able to identify what is a very key pressing issue and bring it to attention. And then I know you always follow through and make sure that action is taken. It's not just that you're not just waving your hands in the air saying, oh no, this has happened. You're also suggesting what could be happening and following that through. So a huge thanks from everybody here on HOSC.
Okay, thank you. Good luck, everyone.
Right, so that brings us to the end of the meeting, members, because we don't have a forward programme, because this is the last meeting of the year. At the meeting of the Overscrew and Scrutiny Management tomorrow, they will be looking at the suggestions for the work programme that have come in. I think there's still time that if you want to suggest anything that you think any of the Overview and Scrutiny committees should be looking at, please send an email to Neil Carr. And tomorrow the Overview and Scrutiny Management will, I was going to say divvy them out, but that's probably not quite the right phrase, to, what HOSC would get, children's services, corporate and community, or would stay with management. So if there's anything that, you've always thought should be scrutinised or one of your residents has recently brought to your attention, please do send an email in and we can try and put it onto the forward programme. We do, however, have a few things that we didn't manage to look at this year that I know we did all want to dig into. We've had 2 additional meetings. We weren't able to have more, so there are going to be some things that we will be putting in the beginning of next year. I think mental health particularly was top of the list. What else was another?
We have got the health and wellbeing strategy action plan is for June, and as Councillor Swaddle says, mental health and the autism, the continent survey service, and the autism strategy when it is ready.
Yeah. Right. So do you can send me an email or send it to Neil. But if you think of anything we should be looking at next year, we can try and put that onto the programme. And good luck, everybody. Perhaps I'll see you here in June. Oh, but I will say that a special thank you to Barry Patman and Jenny Cheng, who are retiring from the council in May. So they're not going to be with us in HOSC next year. So thank you for all of your questions this year and your interest, and I hope you enjoy your retirement. And thank you very much to Madeline and Callum tonight.